everybody. Welcome, welcome. My name is Jinwanjama, as usual. Today we're going to have an interesting, I hope it will be interesting, talk on emergency care for the suicidal patient. I'm sure we've all come across this one way or another. And I'm sure for some people it's not their most confident thing to manage. However, as emergency care providers, as medical caregivers, we need to be abreast with a wide range of things. We usually say emergency care providers go a mile deep and an inch wide. Yeah. So you need to know something about everything. Okay. All right. So just by definition, suicide is intentional attempt to take their life. Could be successful or could be unsuccessful. So most of the times you'll get the patient we're going to discuss today is the unsuccessful attempts. Okay. All right. So maybe we can talk about the numbers. So globally, suicide is the fourth leading cause of death among people aged 15 to 50. And what that translates in Kenya alone, in the latest Kenya Demographic and Health Survey, about 1,576 deaths were attributed to suicide between 2020 and 2024. However, I'm pretty sure this number is a lot higher because most of them go unreported for multiple reasons. Whether it's just generally, there's always the psychosocial aspect about it being a taboo thing, but also just data leaving different levels of healthcare facility to the KDHS tends to vary a lot. I've personally not gotten any data on the burden of the number of attempts. And this makes sense because it's very difficult to report a suicidal attempt as it is a very complex matter. And by law, suicide is considered illegal in Kenya. Per Section 226 of the Kenya Penal Code, it stipulates that any person attempting to take their own life is guilty of a misdemeanor and is subject to imprisonment for up to 2 years, a fine, or both, with the minimum age of prosecution being 8 years. From 8 years, anybody can be prosecuted. So this is quite sad. And there are different endeavors to decriminalize suicide. So that is also an ongoing conversation that you should keep in the back of your head. Okay. Now into the crux of the matter. When a patient comes to you who has attempted suicide, one way or the other, there are many different methods that are used, and different places globally have ranked different methods differently. Commonly, there are attempts by substances, poisoning. That's a common one. There are attempts by hanging. There are attempts by like self-injurious lacerations, like cutting their arms, other body parts. And then in more developed countries, or even with certain cadres, death by firearm. Yeah, those are some of the most common ones globally. Okay, so what do we do when a patient who has attempted suicide is brought to you? Okay, so there are two different ways that they could be brought to you. One, they could present on their own and say, oh, I'm thinking about committing suicide, or I tried to commit suicide, I did this, that. Or they could be brought in by somebody who found them. So usually a relative or an next of kin or even a bystander, honestly, could bring them in. So those are usually the two paths in which they will appear in your emergency department. However, rule of thumb, we will go down 4 steps with regard to how you approach this patient. So number one, as we are emergency care providers, resuscitation takes precedence. So that's number one, you go your CABC. So we'll talk a little bit about that. Then suicide is not It's not like trauma or hypertension or other things. So it does have a modified history taking process that goes along with it, and examination as well. Then you risk stratify your patients, high, medium, low, and that helps you in determining what your disposition plan will be for these patients. So we resuscitate, then we take a history that's targeted to the suicidal event. Then we do risk assessment and stratification. Then we formulate an appropriate disposition plan based on your patient parameters. So these are the 4 things we will talk about tonight. Okay, so like we said, upon presentation, first things first, always resuscitate. Rule of thumb, resuscitate first. You must have somebody with you so that you can go to the next steps, right? So this depends on the mode of the event, what type they used. So with our ongoing modifications and resuscitation, we use CABCD because, like I said, it could be a stab wound, a cut wound. So major bleeding or major hemorrhage comes first. So your circulation, if there's a major bleeding, you want to stop that. Then you attend to your airway if there's like a hanging patient, plus C-spine because there is a hangman's fracture that could have occurred. Then you go to your breathing, circulation, disability, and your exposure, and then your secondary survey. So with regard to that, that remains the same. So yeah, catastrophic hemorrhage, C, then airway, breathing, circulation, disability, and then your exposure. Okay. And in exposure, your random blood sugar is very, very important, as well as an ECG, especially if the mode of attempt involves different medications or different kinds of drugs. So there are some drugs that have effect on your cardiac cycle, number 1. There are some drugs that will make a patient become hypoglycemic. So those are important to remember in your disability and exposure as part of your triage and resuscitation. Okay. So once you've stabilized this patient, you've addressed any life-threatening injuries or life-threatening situations, whether it's a medication. Also, I forgot in this, there's also a role for an antidote, but you always resuscitate first. So once stable, we move to teasing out the details surrounding the event. Okay. So, like I said, mode use, you want to know drugs. What are the potential adverse effects of the drugs? Cut wounds, are there catastrophic hemorrhages that need to be stopped? Do we need to suture a couple of things? Are we applying pressure dressings? If it's hanging, is there compromise to our airway and our C-spine? Do we need to intubate? Are we putting head blocks? So you anticipate possible injuries. And then in terms of your quick glance of your patient, in terms of the signs and symptoms they're presenting with, it can also give you a clue as to what agent may have been used. Like if they smell very chemically, they're full of secretions, they maybe soiled themselves, they have very noisy breathing with wet chest, you're thinking maybe organophosphates. So you want to also still follow the pathways for each of those kinds of things, like you decontaminate them, remove all the clothes, clean the skin, get your IV cannulas, use antidotes as appropriate. If you're thinking organophosphates, your atropines and pralidoxins come into play and are very, very important in getting your patient out of the dangerous life-threatening situation they currently are in. Okay. Then depending on the mode again, you'd need to involve other specialty teams, whether medical or surgical, as needed. Like I said, if they have a catastrophic hemorrhaging wound, bleeding wound, maybe they cut their wrists, then they cut through an artery, you'd want a surgical team to come and repair that or at least address that kind of bleeding. But in the interim, before they arrive, pressure dressings, remember that. So resuscitation is just around what you can see and what you think could be happening. and resuscitating in a systematic manner. Okay. Once the patient is stable, or if your patient did not require any resuscitation, we go to our history taking. So our history taking, initially, the first things first is identifying if your patient has capacity. Some mental health illnesses predispose somebody to or make somebody more high risk for attempting suicide, and ascertaining their capacity through basic questions to see if they can understand what you're saying to them, what you need from them, and make decisions around their care that are in their best interest is very, very important. So that's number one. You must ascertain capacity. Number two, you have to get consent. So consent here involves making it clear in a sensitive manner that you're going to be asking questions around suicide, possible attempts, and things around their mental health, their social circumstances, and their family situations. So you must gain consent and establish a form of trust with your patient before you delve into deeper questions. So once you've ascertained, yes, there's capacity, and two, yes, there is consent to go on further, you can continue. If there is no capacity, you'd want to speak with either their caregiver or what our Mental Health Act calls a supporter. So their caregiver, next of kin, or somebody, or their guardian, especially if there's a minor, you want a guardian present or some next of kin who is like a documented next of kin, like a wife, a husband, or like I said, parent or a sibling. Yeah, but based on the dynamics of the patient, somebody who can make decisions for them, and who would be recognized by law. Very important to establish those before you even delve deeper. Okay, so once you've established that, you go into establishing whether there's actually suicidal ideation or not, if there's a suicidal attempt or not. Once you know that, then you go into what we call our suicide assessment 5-step evaluation and triage. So it's a 5-step process where you ask specific targeted questions to identify risk factors, identify protective factors, conduct an inquiry around the event, and then determine the level of risk of the patient so you can choose an appropriate intervention, and you must document all of this. If it is not documented, it didn't happen. It's all in your head. Okay. So let's talk about the risk factors with regard to suicide. So number one is regarding, was there any suicidal behavior prior to this presentation, whether they've come with an attempt or they've come just with ideation? We want to know, have they tried it before or not? If they have tried it before, was it that it was unsuccessful and someone found them, or did they abort the suicide themselves, and why? Okay. Then have they had any previous self-injurious behavior? Have they been cutting or any kind of self-harm? So you want to elucidate that kind of information at the jump. Like I said, you've started by telling we will be talking about these kinds of things. And there's something I heard when I was doing this research, that asking about suicide or talking about suicide will not make your patient commit suicide. So don't shy away from asking these questions, because the risk of you not asking these questions would be that your patient could end up being discharged as quote unquote low risk, and yet they actually have very high suicidal ideations and intent. So you want to know ideation, intent, is their plan, those kinds of things must be asked. Okay. Then you want to know, are there any current psychiatric disorders or past psychiatric disorders? Have they been treated for any mood disorders, your bipolar mood disorder, your depression, your anxieties? Do they have any psychotic disorders like schizophrenia or schizoaffective or the delusional ideations? Are they having any form of alcohol use and abuse or even dependence? So you want to know, is my patient currently already struggling with all of these things, or did they struggle with them at some point in their recent past or in their past? And how did they manage it, if at all they are? Okay. So then you want to find out, aside from psychiatric disorders, are there any what we call cluster B personality disorders? So these are your conduct disorders, antisocial personality disorders. Are they being aggressive? Those kinds of things. So you just want to ask a few questions. Have you ever seen a psychiatrist? Have you ever spoken to a psychologist? Have they ever given you a formal diagnosis? What diagnosis could that be? But also some of the times, a lot of the times, the answer will be no. So you need to ask very targeted questions to try and tease out these things. You're not there to diagnose them, you're just trying to identify risk factors. Then you want to know, how has your health been of late? Is there a new diagnosis of a chronic illness? Have you been diagnosed with high blood pressure, malignancy, HIV, hepatitis B, anything under the sun that is a chronic illness? If it is a recent diagnosis, tends to have quite a heavy mental load. So you want to ask those kinds of questions. Have you been diagnosed with a new illness? Okay. And then in terms of past illnesses that have already been diagnosed, they've been living with them for a while. What is the burden of that disease on them right now? Are they feeling depressed? Are they feeling hopeless? Those are trigger words that you need to tease out. If they don't voluntarily offer those words, you can ask, are you feeling hopeless? Are you feeling very anxious and panicky? Are you sleeping well? Are you having hallucinations? Have you lost interest in things that used to bring you joy prior? So that's what anhedonia is, just lack of inability to have joy or pleasure, and more so around things that previously would bring them joy. Okay, so that's in terms of the symptoms. Then you want to know a quick family history, okay? So do we have family history of suicide? Some families have a very heavy suicidal burden. Maybe the father, the uncle, the brother, So some might have a heavy burden of suicide. You want to find out, what is your family history? Is there any family history of suicide, and which relative committed suicide? So if it's somebody who was close to them, that has a heavier risk burden than somebody maybe they barely knew. Okay. Then you also want to know, are there any psychiatric illnesses in the family? Yes or no? Are they being managed? Yes or no? Have they ever required hospitalization? Yes or no? Okay. And how that has impacted them as well. It's very important to ask. Okay. Then we go into triggers. So you want to tease out, are there any possible triggering events that has led to this suicidal ideation or the event currently? So are there any triggering events that have led to humiliation, shame, or despair, like if they've lost a job, or if they've lost a partner, even their family, their kids, when there's separation between two partners and it's a home with children and they're left alone, that can be quite a heavy triggering event. Did they lose their job? In this economy, their financial status, how bad has it dropped? Especially with the new taxes, it's quite a heavy load. So you want to know, are there any triggers in terms of their social relationship? Are there heavy dependencies on alcohol and drugs, recreational drugs? Do they have any ongoing, like I said, ongoing medical illnesses or someone close to them that is like chronic pain or prolonged unexplained illnesses, like those patients who come to the hospital every other week complaining that, oh, there's this pain, oh, I'm not feeling well, da da da. But when you see them, there's nothing clinically wrong that you can pick up. That can also have a heavy mental toll. Okay. So you also want to know, was there any history of physical or sexual abuse, whether it's in the immediate past or even in childhood? Those are key triggering events, especially people who were abused in their childhood. They might have like an incident that re-triggers them and bring like a PTSD type of situation that makes them relive all those things. Or maybe they have been confronted by their abuser, things like that, especially because it is well known that most abusers are people who are close to you. So are they in that kind of situation? Is that what is triggering them further? Or maybe have they had a big move? Maybe they've moved for work, they've gone to a new town, they don't have any friends, they don't know anybody there. That can be a bit of a distressing situation. That can make it difficult for somebody, especially if they don't have coping mechanisms. That's a big risk factor. Okay. With regard to those who are on treatment for psychiatric or psychological disorders, you want to find out, have they ever been admitted for this problem or not? Have they recently been discharged from hospital? Have they recently gotten a new treatment regimen, or their medications have been adjusted? It is well documented that some antipsychotic medications on the onset of treatment can precipitate suicidal ideation before they get you to a normal steady state or a good steady state. So you want to know, has that happened? Or maybe their doctor who they trusted or psychologist who they trusted has left and then now they have to start again with a new person. Some of those can be very offsetting for them. So these are the risk factors you want to find out. Then depending on where you are, what the person does for work, do they have access to firearms or equipment that could be used to complete the attempt? Yes. So if we say yes to many of these, that tends to be higher on the risk score. Okay. Now, after you've asked about risk factors, you want to ask about protective factors. So protective factors are the ones that, as the name suggests, are supposed to shield you from precipitating downwards into a downward spiral and possibly a suicidal attempt. So while they may help, they are not foolproof, okay? So some of these can be grouped as internal or external. So internal is how a person deals with stress, stressful scenarios, stressful events. Do they usually cope well? Have they had, so how you can ask is, have you had a previous stressful event? How did you cope with it? And it's all pegged on what they've said their triggering event was. So if maybe a relationship has broken down, you want to ask, is this the only significant relationship you've been in? Have you been in another relationship that didn't succeed? How did you move past that? Okay. If it's something to do with work, how do you usually get through these difficult times? Okay. If it's a family member who's ill, is there somebody that you usually talk to who helps? If you're the one catering all the financial bills, there's somebody who can help you, things like that. In terms of trying to understand how somebody copes with stress. If they have a robust coping strategy, you encourage it further. But if they don't, you need to note it down and see. Another thing, especially in our community, people tend to also lean heavily on their faith. So you want to know, are you somebody who goes to church? Do you believe in some form of higher being or not? Do you lean into your faith and your religion more when things get tough or not? Because a lot of the time, when we're taught in psychiatry, having some form of religious belief tends to be a protective factor as opposed to not having anything to lean on, per se. Okay. Then external factors, protective factors. You'll hear a lot of people say, oh, I'm doing this for my children. Or I'm trying to make it for my wife, for my husband, or I'm here for my parents, that kind of thing. So if they have somebody who is leaning on them and they see it as a positive thing, that can be a protective factor. But on the flip side, if they have someone leaning on them and they see it as more of a burden, that can be a risk factor. Okay. And then do they have social support systems? I think another thing that tend to lean on is group therapy, especially in some mental health institutions, just to give you that social support to see you're not the only one. There are other people also struggling with similar things, and you can make it as well. Okay. So now we move into asking more in-depth questions about the event. Okay. So you'll notice I'm trying to use very specific words like event or incident, because suicide, like I said, is a very sensitive issue. So even when you're speaking with your patient, you want to be cognizant of the fact that it is a sensitive issue, and you want to be responsible in how you portray the questions that you're asking and how you receive the information, so that they don't feel stigmatized or shunned. So specific questions need to be around, have you had suicidal thoughts? Is this the first time? Have you been having them for a while? Do you have an actual plan? What is your plan? Okay. You want to ask, how long have you been planning it? Okay. If somebody is brought in by next of kin or family members or caregivers, you want to ask them, have they been having very strange behaviors lately? Have they been intentionally looking for these kinds of things, or have they been acting more down than usual? Those are some of the questions you need to start with. Then in terms of the ideation, like I said, how often are you thinking about it? How intense is it? Is it just, oh, maybe I should kill myself? Or is it, I need to do it, I need to do it, it's too much, this is too much? And then for how long do you think about it, especially in the last 48 hours? And then in the past month, and when was it like the most frequent or the worst ever? Okay, so those are some with regard to the ideation. Then with regard to the plan, you want to know, do you have a plan? What is your plan? How do you intend to execute this idea? Do you know when you want to do it? How you want to do it? Are the things you need to do the how readily available to you? If you choose poisons, have you bought them? Are they readily available? Are they in the house? Are they at the kiosk outside the house? Is there like a firearm in your house or not? Those kinds of things. And then, like I said, preparatory acts. If somebody goes out and buys pesticide and they don't have any pests, those kinds of things. Have they gone and bought a gun? Have they gone and looked around the house to see where can I hang myself? Those kinds of things. You want to ask very specific questions, but also let them. So you start with an open-ended question. Do you have a plan? Can you tell me more? Then they let them talk, and then you can ask further questions as you go along. Okay. Then have there been past attempts? Yes or no? What happened with the previous ones? Did somebody find you, or did you stop yourself? If you stopped yourself, why did you stop yourself? If somebody hadn't found you in time, would you be happy or would you be sad? Are you intending to do it again? Those kinds of things. Have they tried to learn how to tie the rope that potentially they could hang themselves with? Those kinds of things. So those are on the more extreme side, but you also want to ask about the, well, if they've been self-harming, are they cutting themselves? Maybe one day they tried to nick themselves on their hands to see how deep it would be. Then they stopped. Then the next time they cut even deeper. So those kinds of things, are those present or not? Then, so you want to explore the reasons behind all of this, okay? Do they have, it's like a pros and cons list. Do they have a list of why they want to die versus why they want to live? Does the reason for wanting to die really outweigh the reason for wanting to live? So that's a very important question to ask. Tease it out of them. Do you think you have anything to live for? Do you think the world would be better without you in it? Do you think your family would be better off without you in it? Those kinds of things. If they're younger patients, or if they're not fully conscious, the ones you've resuscitated, you want to ask the guardians or parents about their behaviors in the last couple of weeks or months, about the conversations they've been having. Are they seeming more sad than usual? Are they sleeping? Are they not sleeping? Are they staying in their room longer? Are they eating? Those kinds of things you need to find out about. Okay. All right. So now that you've asked those questions, so we've done the risk factors, you've asked your questions, we've teased out protective factors as well. Then we've gone in depth into asking about the suicidal event or intention, ideation. Now you want to put it all in, basically just compile your thoughts and see where your patient possibly lies, okay? This is not a hard and fast chart. This is just one of the things that you need to also write down as your possible red flags. So high risk patients, they tend to have psychiatric disorders with severe symptoms or an acute precipitating event, major life event. Then they probably don't have any protective factors, or the ones that they have been overcome by how bad everything else is going on. Okay. Then in terms of the suicidal ideation or intent, the method that they have a foolproof plan, well thought out, like step by step, and it is highly lethal. Okay. So these patients, if they fall into this category, you should really admit them. Okay. You should really admit them. Moderate are those who have 1, 2, 3 risk factors here and there. They might have some protective factors. They might have sort of a vague plan, like, oh, maybe I should, I don't know, hang myself, but they don't currently feel like they've not gone out to seek these things. They don't feel completely down. So they just have the idea in their head. Okay. So these people, you have to consult psychiatry in one way or another, because you may admit them, because you would need to still ask more questions around even like their social support. You might need to admit them, but you need to consult the psychiatry department or psychologist and formulate a plan in conjunction with the patient that works for them. But you just don't let them go. You have to develop a plan in case things escalate and get worse, and they need to be able to reach the hospital and things like that. Okay. Low risk patients, those ones who maybe have like an acute trigger that can be modifiable, like maybe they've recently lost their job. Maybe they sound like they have some interviews lined up, there are some prospects, things that can be modified. And they have like a strong social support. They don't have any barriers to care, especially psychiatric care. these tend to be more low risk in terms of their risk profile. In terms of suicidality, maybe they've thought about death one-off or two times, but they don't have a plan. They don't actually have any intent, and they don't have confounding behaviors that make you think that they'd probably do it sooner rather than later. So for these, we tend to discharge them through the outpatient clinics, and not a delayed referral like tomorrow or in the course of the week, right? Give them a plan on how to reduce symptoms or cope with the symptoms, as well as numbers that they can call so that they can reach you. Or a hotline. I don't know if we have hotlines. We should. Okay. So just like we went through, these are some of the risk factors, that high risk factors, or those associated with increased risk of suicide. So yeah, it's just everything we've been talking about. With regard to the suicidal thoughts, they're high risk, they have a clear plan, intent, they've probably tried it before, and they're quite hopeless. They have baseline psychiatric disorders that are quite disabling. They may have gotten a recent debilitating chronic illness diagnosis or have been living with one for a while and it doesn't seem to be getting better, so they're losing hope. Things psychosocial, lack of family or social support, recent unemployment with a drop in socioeconomic status, domestic violence, things like sexual or physical assault or abuse. If there's a strong genetic loading where there are family members who have committed suicide, who have died by suicide. If there's a family history of mental illness, if they have, like I said, the hopelessness, anhedonia, shame or humiliation, basically seem quite depressed, they're not functioning normally as they would. Those are some of the things. Another thing, male gender tends to be more high risk than female. World over, that's just a fact. Yeah. And then in terms of demographics, age demographics, it changes with region and locale. Okay. And then access to the means, especially like firearms or the substances that they think they can use to commit the act. Okay. All right. So after you've talked all of that, please note it takes a lot of time. Definitely takes a lot of time. And you can't rush the process. Because if you rush the process, one may feel dismissed. So yeah, as you go through all of that, you need to document it all, write it all down. Write down all the risk factors you've identified, write down what the suicidality is, write down what their protective factors are, if any, write down what their past psychiatric history is and family psychiatric history is. You must write it all down. So now that we've done all of that, there's also, even before we go to disposition, in terms of examination, does the person look well kept or not? You know, the psych mini mental state exam, you do that basically. Do they look agitated? Do they look unkempt? Do they look sad? Is their mood labile or just low? Is there incongruence? Those kinds of things. Do they have fidgety behaviors? You have to examine all of that with your mini mental state exam and document that as well. Okay, good. Now we go to disposition. Okay, so disposition, Where is your patient going to go after you've had that lengthy conversation? Are you admitting? Are you discharging? Are you sending to the clinic now or later? So there are many rating scales that have been formulated. We will discuss one, but there's very many. They are not hard and fast. They merely serve as a guide, okay? But we always say, clinician gestalt, if you feel like you're worried about a patient, rightfully so, but when you write down all the risk factors, it seems like they're fine. Don't ignore that gestalt or sixth sense, okay? Do the rating scales, yes, but take them with a pinch of salt and apply them based on your patient-to-patient basis, okay? That is the disclaimer. Okay, so we will talk about the modified third person scale. So it is available on MD Calc. It's a fairly easy tool that you can use in conjunction with your other history taking, just to sort of give you a guide onto how safe it is to discharge or who must you admit. So it's similar to what we've just talked about. This is just one of the validated tools. But again, not a hard and fast rule. So third person, it's a mnemonic acronym, whatever those things are called. So S is for sex. If they are male, they're more high risk, so you get 1 point. If their age is less than 19 or above 45, there's a point there. Depression or hopelessness, if they admit to that, that's actually 2 points. Then if they have previous attempts or psychiatric care, if they say yes, that's 1 point. Have they had any excessive alcohol or drug use? If they yes, that's 1 point. Do they have any rational thinking loss? Like when you're talking to them, their rational thinking could be intact, like you would probably make the same thought process and decision. So this is where you give them those questions for if there's a train and there's a person on the train tracks, what do you do? Those philosophical questions that we were taught to ask regarding rational thinking. So if they give an answer that seems rational and that hopefully you are a rational person because you are the standard we're using, if you've both come to the same rational, logical decision, then that's fine. If they do not express a rational thought, they score 2 points. Have they been separated, divorced, or widowed? Yes, is 1 point. Do they have an organized or serious attempt? If they say yes, that's 2 points. Those are the ones who have the well thought out plan, okay? Then do they have social support? Yes or no? If no, you get 1 point. If yes, no point. Then is there a stated future intent? Meaning, especially these are the ones who have attempted and failed, and then you ask them, if you're given the chance, would you try again? And would you try with something more foolproof? Yes or no? If the answer is yes, that's 2 points. So when you submit all these things and they score less than 5, it's deemed as low risk, okay? Again, pinch of salt. It's deemed as low risk and the patient can be managed as outpatient through the clinic, okay? If it's between 6 to 8, it's a moderate risk. You could consider admission in conversation with the psychiatrist or psychologist, whoever is managing the mental health patients in your facility. So you have to have a conversation and then formulate a plan. If your patient, in terms of your plan, is likely to adhere to it, likely to come back to the clinic, likely to follow all the steps that you want to give them, you can discharge them. However, if there are any barriers to care, it's like when we did ETAT for diarrhea and pneumonia patients, if your patient stable and is able to be brought back to the hospital for evaluation, you can let them home. So it's similar. If they don't seem confident in following your plan that you've made together or coming back for review, you'd want to admit them, okay? Or if there's any form of barrier to care, you want to admit them. If they score 9 and above, this is a high-risk patient who should be admitted. Plain and simple. Because if you let them home, hapa kwa stated future intent, they might come back having been successful. Okay? So this is a tool you could use, not a hard and fast rule, but it can help you guide your way through it. Okay? All right. Okay. Now, for the ones you're considering discharge, okay? Your low risk and moderate risk patients, you must involve the patient in the decision-making process, okay? Because at the end of the day, they're the ones who are given the bulk of the duty of care, right? Because you want to make sure they will be able to take care of themselves, right? So a shared decision making. You'll tell them, this is what we'd like to do. What do you think? Can you do this? Can you do that? Making that conversation and those decisions together tends to help relieve them of some stress because they feel like they're not in this by themselves. Okay, number one. Number two, if they're part of the plan, they're more likely to follow through with it because it's also their plan. They can take ownership of it. And eventually, this should lead to better adherence and outcomes. Okay? Yeah. So yeah, patients with suicidal risk report higher satisfaction when they're involved in the decision about their care. Ideally, this should actually be what we do with all of our patients, okay? All of our patients should be part of the decision-making process, but more so a patient who is having mental health struggles, especially related to suicide, okay? Then for your follow-up, like I said, it's not next month or in 2 months, no. These are the patients who need to be scheduled sooner rather than later, and that's within 1 week of discharge or a few days from the review date. If you can get, especially for your low-risk patients, if you can get them seen the next day or the next 2 days, that's better, but shouldn't be longer than a week. When you're making the plan, they must reiterate what the plan is to you so that you understand that they understand it, okay, and that they will stick to it. So ask them to reiterate, ask them to ask questions, and then also troubleshoot possible hindrances here and there, okay? So you discuss any barriers. Do they have any issue? Do they live really, really far that they can't come to the hospital? Can they stay with somebody closer who lives closer? Things like that. Do they live alone? Can they stay with somebody who can take care of them? Those kinds of things. Then a crisis phone number should be issued. What number can they call in the event that things don't improve and start to decline? Okay. Then if they have easy access to a lethal mean like a firearm or other things like that, discussing how to get that out of their reach. If it means them leaving their home where that firearm is stored, that's great. If it means storing that firearm somewhere else, that's also great. If it means, again, living with somebody else temporarily who understands and is empathetic to all of this, that's also a way you can do that. All of this has to be written down because we are all humans, we forget. I've probably forgotten what I said at the start of this presentation. So you need to write down the plan so that they can also refer to it when needed. And even if they come back to hospital and they don't find you there, or they find, especially when they're coming to see the psychiatrist or psychologist, they can show, okay, we talked about this. I'm supposed to do this if this happens, those kinds of things, okay? And also your red flags of when should I go back to the emergency department or what can wait for the psychologist. Okay. Again, make sure you confirm that they've understood. Yeah. If you're starting them on treatment, you also need to talk about possible side effect profile of the medications. Also write that down so they can also refer to it just in case something happens to them and they weren't expecting it. Yes. After you've had that very lengthy discussion, the patient understands what's happening with them, what they need to do to make themselves better, and you're more likely to succeed with rehabilitation and improvement of their current status. Yes. Okay. So, yep, that is an hour of our presentation. We can go into, let me just summarize again for you guys using this. So like we said, patient could come in by themselves or brought in by somebody who cares about them. First things first, you want to resuscitate them following your CABCDE. You want an ECG, you want a blood sugar, especially in the case of toxins. You want to give antidotes where appropriate, okay? Once you've resuscitated, you can take history either from them or the person who has accompanied them, who knows them well enough. History taking will follow the identification of risk factors, identification of protective factors, a thorough suicidal inquiry, and then risk stratification of your patient to know whether they have high risk factors which need to be admitted, whether you can just do a quick psych consult and schedule them for outpatient management or follow-up, okay? Then you write it all down. Then you make a plan with the patient, the ones who are being discharged. The ones you're admitting, you admit and make a plan with psychiatry. The ones that you are discharging, you make a plan on the things that they need to do, how they can get support, how they can get to the hospital, when to come to the hospital, so that it doesn't happen again. Yes, that is the end of my presentation. I welcome questions and comments. Lilia from Mexico. Hello, welcome. Okay, then there's a question in the Q&A. Julia Sakong, after how long of ingestion of poison can one not do gastric lavage? So, gastric lavage is contraindicated through and through. We don't do it anymore, so you shouldn't be doing it at all. That is the only answer to that question. No more gastric lavage. Richard Alembi asks, how long should the patient visit outpatient clinics? As long as they need to. Yes, as long as they need to. So that's specialty outpatient clinic. As long as they need to, they keep going there. Yep. So the trajectory with mental health, there are good days, there are bad days, there are good moments, bad moments. So structuring very patient-centered, personalized care is very important, because when they're in their good phases, they might just need once in a while. When they're in their bad, not so good phases, they need closer appointments and follow-ups and strategies where they can learn about things like cognitive behavioral therapy and all those nice things. Yes. Okay. So then someone asks, how do you manage the socioeconomic factors in a patient who needs admission but cannot afford it? Okay. That is always a tricky question. Always very difficult to navigate. However, first things first, there's a Mental Health Act. that is in one of our laws, okay? Cap 248. So just like emergency care is a right for everybody, mental health is a right for everybody. So if they cannot afford it, if it's like a private facility, you can refer them to a government facility. You can refer them to places like Mathare, where duty of care is guaranteed by law. Yeah. So that may be one way. Okay. Okay. Somebody wants to look at third person scale. Okay. So like I said, you can score 1 or 2. Positive answers score 1 or 2. The ones with a red star are 2 points. And then if it's sorry. So if it's less than 5, you're low risk. Should be managed outpatient, but that is also to the discretion of the emergency care provider. 6 to 8, moderate, can admit, can discharge, but urgent, but you need to involve your psychology, psychiatry. Then 9 and above, admit. Okay. Is there any role of ICU in the care of suicidal patients? So if a patient is going to ICU, it's because depending on their mood, they have gotten some physical life-threatening injuries. Maybe they've been intubated, maybe they've had a catastrophic hemorrhage, they're unconscious, those kinds of things. Those ones would end up in ICU, but not just because of like the mental health aspect, but also the physical health aspect. Okay. So how long should they be put on on psychiatric medicine? Is it short term or long term? Again, that is up to the discretion of the psychiatrist. So if you're discharging and you've consulted psychiatry, psychiatry are the ones who prescribe, and they've recommended that they should be put on some form of psychiatric medication, they should be seen in clinic and they will decide when to continue it, what to change, when to stop, those kinds of things. But those ones are clinic, not urgent things, emergent things. Okay. Is there a local suicide watch contact 24 hours? There was a time there was, I'm not sure if it's currently functional or not, to be honest. Yeah, so unfortunately, I don't know if it's still. But luckily, the discussion on mental health is on the up and up. It's becoming a more forefront thing to discuss. I know there are private agencies that also offer like counseling on the phone services and things like that. Yes. So Linda asks, for high-risk patients who may require intubation, which drugs will you use for sedation and paralysis? Again, it is in the context of what is happening with your patient. The only thing that's usually contraindicated is if your patient has taken organophosphates, your paralytic, you cannot use succinylcholine because they work in the same way. You'll just have prolonged muscle degradation. So that's the only thing, but also other patient parameters need to be considered. Is your patient hemodynamically stable or not? Also, what agents do you have in your facility or not? Yeah, so if your patient has low BPs, you might want to steer clear of propofol, midazolam, those kinds of things. Yeah, so it's just based on patient parameters. What is happening with your patient? Is it an ingestion? Could it be OPP? What are their vitals? Those kinds of things. So if the stressors are not removed, are these suicidal thoughts able to be completely avoided? It's anything is possible, honestly. If your stresses are not removed, there's also a role for learning how to cope with them. And then it also depends on what the stressors are. Okay. If it's non-modifiable stresses, like your family member is sick, you want to help them find a way to mitigate how much they are stressed by it. maybe by looping in another family member, things like that. So it all honestly depends on what they are, and if there are ways you can help them cope. Like we said, in the outpatient management platform, there's also a role for cognitive behavioral therapy, where you can be taught skills and techniques that you can do in a stressful scenario to help you cope with it and get better. Okay. Okay, if a patient has a modified third person scale of 9, can you administer ECT as a first line? I am not a psychiatrist. You would have to speak with the psychiatry department on that one. Yeah, and then also ECT, there are like prerequisites and criteria you need to meet for you to be done for ECT. So they could have a modified third person scale of 9, but it's because of family stress or other things that are not like depression related and things like that. So again, on a patient-to-patient basis, in collaboration with the psychiatry department, and the guidelines on when to administer ECT are very important. Okay. Okay. What has replaced gastric lavage? Okay. So since we do not do gastric lavage, there's still a role for activated charcoal in specific scenarios. So even if you go to the casualty app, actually all this information is on the casualty app, the emergency care guidelines. So there's a role for activated charcoal in some ingestions and within a specific time. So not everybody gets it. So those are some of the things that you could possibly use. And then now in terms of managing what is it called? Managing the signs and symptoms that come about. So activated charcoal only given within the first hour of ingestion. Yeah. Yes. And it doesn't work with a couple of things. So just, yeah, refer to the casualty app. How do we differentiate between suicide and attempted murder? And when do we inform the authorities, especially in an unconscious patient? That's a very good question. And that's a very difficult situation to be in. Okay. First things first. Suicide, like I said, is a very controversial thing. Like we had done at the start, right? It's by I stopped sharing. So like we said, by law, it's illegal. However, the good thing about the human body is it can give you clues as to what could be happening. And this is what even the whole essence of pathology is, right? And postmortems. So when you're examining your patient, actually, let's even start from the history. Whoever brings the patient in, if their history does not make sense, the history being provided does not make sense, that should raise a red flag, number one. Number two, when you're examining your patient, there are things called defensive wounds. Like if somebody has lacerations on their forearms on this side, that's a defensive wound. So you want to take a history and correlate it with what you're seeing clinically, because the body never lies, right? The body doesn't lie. So correlate with it with what you're seeing clinically. And then if there are any red flags that come up, even from the history and from the physical exam, that point towards a more sinister path, that somebody has been hurt by someone and it's not self-harm, then you have a duty to report that. However, under the same Mental Health Act, every person has a right to mental health care, right? But they also have a right to their own privacy. Yeah. So you can't go disclosing somebody's private medical information without cause or warrant to the police. So it would be very, very important, like I said, examine fully, take the history. If there are any red flags, there's always there's always a protocol in each hospital that you can follow to raise alarm. Yes. Okay. Okay. Let me see. Okay. Okay, let's see. This side is there. At what point do you rehabilitate mental health clients to their normal professional duties? Again, that is not to the purview of an emergency care provider. That is why all patients have to be plugged to mental health care provider. So they are the ones to say, are you fit for work or not? Mimi siwezi sema. Mimi nitakuresuscitate, nikuadmit, ama discharge through mental health clinic. Yep. So it's up to them to assess their status and their progress. And it's never just a one visit type of thing. It's an ongoing process. Yeah. There's a question. Is alcohol intoxication considered a suicidal attempt? It depends. Yes and no. It could be yes, it could be no. This is where now the history surrounding the circumstances of the event comes into play. Did they just take alcohol alone? How much alcohol did they take? Were they taking it alone? What was the intent when they were taking that amount? Those kinds of questions come into play. So once you determine all those questions, and if your patient is awake to tell you yes or no, then that's what determines it. Okay. How do we offer psychological help to a person attempting suicide? Again, so once you evaluate your patient, from your history taking to your examination, your risk certification, and you deem them necessary to go home, one, you formulate a plan that they agree with, which involves identifying their triggers and giving possible solutions, possible coping mechanisms, number one. Number two, we are discharging them through a mental health clinic, okay, where they can get further information on how to cope, CBT, medication, follow-up plans, those kinds of things. So thank you guys so much for joining us today. This has been very fun to do with y'all. So feel free to read more around the topic, read the Mental Health Act to see how you're doing. And make sure you download your casualty app and have a look at how to manage this patient, because the guidelines are also there. So good luck. We hope that we continue to serve those who trust us to help them better.